Ganesan sir, and our Director, Madam Chancellor, Dr. Anuradha Ganesan ma'am, on behalf of our Department of Ophthalmology, Arpadevidu Medical College and Hospital, I welcome our Dean sir, Professor P.F. Kotur, and our Dean Professional Health Profession Education, Dr. V.N. Mahalashmi ma'am, our Director Medical Research, Professor B. Vishnu Bhatt sir, our Medical Superintendent, Professor K. Jayasingh sir, and our guest speakers of today, CME, Dr. Kavitha ma'am, Dr. Vijhaya Priya ma'am, and Dr. Josephine Christy ma'am, our Vice Principal, Dr. Rajan sir, Dr. Arunachalam sir, Head of various departments, senior and junior faculty members, postgraduates and undergraduate students, optometry students for this CME on eye donation awareness. We observe National Fortnight on Eye Donation from 25th August to 8th September every year under National Program for Control of Blindness and Visual Impairment. This year, it is the 36th National Fortnight, which is aimed to create public awareness and to bridge the gap between the demand and the supply of the cornea. Hope you all will be benefited by the CME and enjoy yourselves. Thank you.
Thank you, ma'am, for your brief and blissful address. Now, I invite our most respected Dean, Dr. P.F. Kotu, sir, for his presidential address. Please, sir.
Yeah. Good morning to all the participants and the resource person over here. I am indeed privileged to welcome all the resource persons from the other institutions, the Indira Gandhi Medical College, then the Changalpattu Medical College, Dr. Kavitha, Dr. Vijhaya Priya, and Josephine Christine from Arvind Eye Hospital. This is to commemorate the Awareness Week fortnight celebrated every year for eye donations. And I compliment the team led by Dr. Kalaiselvi from the Department of Ophthalmology of AVMC to have chosen to have this CME inviting the experts in the field. Now, some thoughts or something, some information I like to share on this occasion. We all know that this eye donation is one of the accepted modalities to treat the blindness. And in a country like India, developing countries, the main cause of blindness is the cataracts, especially in the elder age group, which has the definite gold standard of treatment, that is the eye donation or corneoplasty. And the demand supply ratio is so much wide. There's a big gap between the demand for the eye as transplantation, corneal transplantation surgery, and the demand. We are not able to even cater to 10%, I think, maximum, not even that much of the people who need, and how many corneas are harvested every year and transplanted. So there is sky is the limit. I must at this point of time, the Lions Club also does quite a lot of work, and of course other private players, they all have been trying to contribute. In spite of that, one thing is true, that the efforts are not enough to counteract the need, or the dire need of eradication of blindness. Even in government of India has pumped up so much of monies, millions of crores of rupees in that national blindness program. All those things are in place, but the target is quite far. But something is, there is something ray of hope that we are progressing day by day. Now, on this, I was thinking, every organ they are preparing artificial thing, including artificial intelligence they are doing. Why not artificial cornea? When there are so many wrong notions about eye donation, people are reluctant to donate their cornea. Those are, so many things are there. In that, why not think of, I remember to have done some premature, the marketing has happened or not. Ophthalmology should be able to tell me. Some Israeli company had put this artificial cornea, that was some non-degradable, non-nanofiber filament or something of that kind. which was put on some clinical side, and some multi-centric trials was also planned. This was newspaper information I am trying to share. The moment we said this Israeli company startup, they had put up in the market artificial cornea, my memory goes back to almost 2.5 decades back, when there was a time for artificial blood. Again, it was an Israeli company which has prematurely marketed that artificial blood, the fluorinated compounds, and caused so much of morbidity and in some mortalities as well. If we remember correctly, it was almost, I was just completed my PG. It was somewhere in 1987, 88, I think, and almost how many 40 years back, and it was a big top news in the newspapers, and that artificial blood which was put was taken aback in the market, was taken aback with some black stigma passed on that. And such things we keep hearing. No other country, I think, to my knowledge, has ventured of putting some synthetic, of course, a patented material, they say, into somebody's eye below the conjunctiva, so that it will function as a cornea, a lot of them. But anyway, there is a ray of hope. I think our ophthalmology colleagues who are over here, and Josephine, Christine, she's speaking especially on eye donation surgical aspect. She should be able to throw some light on that.
Yes, sir.
And certainly good. And I'm on behalf of our management, on behalf of our university, I take this opportunity of welcoming all the participants to AVMC for this single day CME, and I'm sure the students will immensely be benefited out of the knowledge and the expertise of these resource persons. With this, I wish you good luck to all of you and fruitful deliberations. Thank you very much, Dr. Kalaiselvi.
Thank you, sir.
Thank you, sir. Next, I call upon Dr. V.N. Mahalakshmi ma'am, Dean HPE of the esteemed institution, for her opening remarks. Please, ma'am.
Thank you, Amrita. Good morning to everyone present here. And it's nice to see a lot of new faces. Dr. Kavitha, I think we had seen her once in some of the CME. And also the other speakers. A hearty welcome to you on behalf of AVMC. This outreach programs, especially trying to motivate the public and asking them for a donation of body parts. I think ophthalmologist is the specialty which started with that, and whatever other systems have taken is mainly from them. Either it is body donation, or it is organ donation, or for transplant donation. I think the predecessor for all these movement has come from ophthalmology only, and like I do not know, like I'm seeing these kind of programs on awareness programs for quite some time. Consistently, year after year, they do it in the first week of September. And it is very nice to see different people talking about different aspects of eye donation, not only the medical aspects, but also from the social point of view, like how to motivate people and how to ensure that this eyes which are donated are used in an appropriate fashion. So that is, I think, the most important take home from this activities every week. And the second thing is also about our department, and Dr. Kalaiselvi is doing a lot of work ensuring that she keeps the department running, and also she doesn't give an excuse saying that we can postpone things or do things in some other time based on workload and all that. So that needs to be appreciated. And I hope that all the students who are present here, mainly majority of the participants seems to be that, both from our optometry course as well as from the MBBS course, they will get immensely benefited by the deliberations in today's meeting. I wish you all the best and happy learning. Thank you.
Thank you so much, ma'am, for your appreciation. Over to Amrita.
Thank you, ma'am, for your kind words. Next, we move on to felicitations. With great honor and respect, I invite Dr. P. Vishnupat sir, the Director of Medical Research, AVMC, to share his valuable thoughts with us. Over to you, sir.
Good morning, respected Dean P.F. Koto, Dr. Mahalakshmi, our DDHP, Dr. Jaya Singh, Medical Superintendent, Dr. Rajan and Dr. Arunachalam, Vice Principals, the Chairperson as well as Organizing Secretary, Dr. Kalaiselvi, and all distinguished speakers of the day. On behalf of management and my own behalf, it is my pleasure to see you all and welcome you. It is a great occasion because a donation of something always should be welcome. And I am sure that the need for cornea is so large or huge that we do not have enough people to donate. Many times I think what happens is that people want to donate, they sign, the papers are kept somewhere, nobody knows what has been done. And by the time the awareness comes, already cornea might have got dried up. I think that may be the issue, and I think this awareness can not only make people understand that it is important to donate your organ, because after all, after the death, we don't know where we are and what we're going to. So at least somebody else can see through our eyes. I think it is a great, and everybody will be happy to donate their eyes. But it should be more well streamlined so that people who can receive the eyes should be informed well in advance so that the eyes are collected at proper time. And I think the galaxy of speakers are covering most of the issues and legal and technical issues, when to transplant, how to transplant. As Dean suggested, artificial cornea, if it's available, it would have been a great thing. But I think cornea comes in the middle where the vision comes. So even if slightest aberration is there in the artificial material, it will blunt the vision. So probably that is one of the major issues in developing an artificial cornea. But with cell culture and other modern techniques, probably it will not be very long when people can or will be able to make artificial corneas, and it will benefit a lot of people. And as you know, that we do not realize when the organs are functioning, we do not know the advantage of that. Only a blind man can understand, or a blind woman can understand what is the problem of not having eyesight. Similarly, when you do not able to hear or speak, you know the problem. So when organs are functioning and the person is working properly, we do not understand what will happen if you don't have particular function or organ. And I'm sure that this program will stimulate and create awareness of large number of population so that nobody should go without getting a cornea if they are in need. So I wish the organizers and the program a great success. I'm sure that Dr. Kalaiselvi will let's tell next year how many more eyes she could get in this year after the awareness. So thank you very much. I wish you all the best.
Thank you, sir. Definitely, I would give you a report, sir. Over to Amrita, please.
It's an honor to invite Dr. K. Jaya Singh, the Medical Superintendent of AVMC and HED, to this auspicious occasion to share his valuable thoughts with us. Please, sir.
Thank you, Amrita. Am I audible? Am I audible?
Yes, sir. You are audible, sir.
Okay.
Please.
Our beloved Dean, Dean HPE, Director Medical Research, VPs, Dr. Kalaiselvi, HOD in charge, Department of Ophthalmology, AVMC, guest speakers, Dr. Kavitha from my own college, Chengalpet Medical College, and Dr. Vijhaya Priya, Associate Professor, Department of Ophthalmology, AVMC, right? And Dr. Josephine Christy, Consultant Cornea Refractive Services, Arvind Eye Hospital, Puducherry. Heads of all the departments of AVMC, professors, associate professors, assistant professors, senior resident, JR, CRRIs, postgraduates, and students. Good morning to one and all. I sincerely thank Dr. Kalaiselvi and IQSC for giving me this opportunity to give a felicitation in the CME conducted on awareness on eye donation being organized in view of the National Eye Donation Fortnight observed every year from August 25th to September 8th. It's a campaign to create mass awareness about the importance of eye donation and motivate people to pledge their eyes for donation after death. Blindness is one of the major public health problem in the whole world, especially in developing countries. According to WHO, corneal diseases among the major causes of vision loss and blindness. Approximately 5% of the world's population is blind due to corneal diseases alone. In India, approximately 68 lakhs people suffer from corneal blindness in at least one eye. Of these, 10 lakh people are blind in both eyes. The National Blindness and Visual Impairment Survey conducted in India 2019 reported that corneal blindness was the leading cause of blindness among patients less than the age of 50 years in India. In most cases, loss of sight can be corrected through corneal transplantation through eye donation. In India, there are millions of patients who are waiting who require corneal transplantation. Many people are even willing to donate their eyes, but the problem is the issue emerges from lack of awareness among the common public. The motive behind launching the National Eye Donation Fortnight is to raise public awareness about the procedures, benefits, and future aspects of eye donation. The main goal is to bridge the gap between the demand and the supply of eye donation. So far, the eye donation fortnight observation has successfully bridged the gap. This has been conducted for so many years because of observing this eye donation awareness fortnight. The gap is somewhat filled up. There are numerous reasons as to why people do not donate their eyes. Number one, of course, as I already told you, and as many speakers told, lack of awareness among the general public. Second reason will be insufficient facilities in the institutes and hospitals. Third one will be absence of motivation among trained people itself, trained personnel itself, lack of motivation. And of course, in India, the social and religious myths about the eye donation contributes to the lack of donation of eyes after death. As our dean told, actually artificial corneal transplantation has taken place in India. In 2011, the Pune-based National Institute of Ophthalmology has carried out 10 such artificial corneal transplantations in India. Of course, this can be the only alternative for patients in countries like India. This is called as the keratoprosthesis. Keratoprosthesis. But I don't know why this is not taken take off after 2011. Still, we are depending upon the eye donation. I hope the ophthalmologists will go in that line. Will take the artificial corneal transplantation, take it forward. And as Dr. Vishnu Bhatt told, I remember in our institute, AVMC itself, many people have given their consent for eye donation. I remember some 1 or 2 years back, all the faculties and postgraduates in our AVMC campus itself, they have given their consent, written consent written consent for eye donation. I don't know where those papers are lying now. Kalaiselvi may be
Yes,
able
sir.
to.
We have taken the awareness among all the faculties and we have urged them to pledge their eyes, and that has been registered with the nearest eye bank, Arvind Eye Hospital, where there is an eye bank, and hence that registration would be given back to those whoever has registered and
I think
pledged.
this year also we can continue to do that because
Yes, sir.
many new faces have joined, and I requested Dr. Kalaiselvi to take a
Sure,
part.
sir.
I'm sure the CME will create an awareness among the delegates who are all attending, as well as motivate them for eye donation, and in turn will motivate the common public for eye donation. I wish the CME to be a great success. I once again thank the organizers for giving me this opportunity. Thank you.
Thank you, sir. Over to Amrita, please.
Thank you, sir. That was indeed valuable and helpful. I'm extremely privileged to invite Dr. T. Kavitha ma'am, the Senior Assistant Professor from the Department of Ophthalmology from Chengalpet Government Medical College, Tamil Nadu, to enlighten us on the topic social aspects of eye donation. The stage is all yours, ma'am. Please.
Okay, good morning,
Yeah.
everybody. I am Dr. Kavitha, Senior Assistant Professor, Government Chengalpet Medical College. First of
Kavitha,
all-
1 minute. I will introduce you. Actually, I am so honored to get my beloved, the bestie friend who I have. I urge all my students in all the classes that to have a very nice friendship. Friendship is the one which takes you all along, right? So, looking after a graduation of MBBS at 1919, I'm so nostalgic to get her all the 6 years, 5.5 years we spent together. And somehow at various time period, both madam and myself did ophthalmology and we are in the same field. And I'm happy to invite madam to our CME and enlighten our students, both our MBBS and optometry students, regarding her experience in this eye donation purpose. Okay. And here I go to share madam's slide. Please, 1 minute.
Okay, first of all, I thank you all for inviting me for the CME in the Ophthalmology Department in Vijhaya Medical College. I thank especially Dr. G. Kalaiselvi ma'am, Associate Professor, HOD in charge of Department of Ophthalmology, for giving me this opportunity to talk on the introductory speech about eye donation. So in this introductory speech, I would like to tell certain things about what is eye donation, why eye donation is very necessary, and is there enough cornea to supply all the keptoplasty needed nowadays, and who can do the eye donation and who cannot do, and myths involved around the eye donation. So this is the introductory slide. You all know who he is. He's Dinappan, who is popularly known as Kannappa Nayanar. So he's the one who is supposed to have given the eyes, donated the eyes to Lord Shiva, and because of which he became Nayanar, Kannappa Nayanar. So, but eye donation dates back to Kannappa Nayanar age. And next. So why all this eye donation, everything is suddenly coming and popping up during this September, August end and September? It is because of this National Eye Donation Fortnight, which is observed every year during August 25th, between August 25th to 8th of September. So this is this fortnight, this 2 weeks is especially for celebrated to create the awareness among the public and to increase the donation of cornea for making us cope up with the necessary cornea for supplying all the keratoplasty needed. So this campaign aims to create mass public awareness. So we are creating awareness day-to-day life in our departments, and we are taking a lot of effort in the IMCUs, and we have grief counselors to motivate the donation of cornea in the IMCUs where the old patient died. But in addition to that, we want a mass awareness created among the public so that a lot of corneas are donated after the death. So that is the aim and purpose of the National Eye Donation Fortnight, which is observed between 25th August to 8th September. So this is mainly to motivate people to pledge the eyes for donation after death. So we are pledging when we are alive, and we donate after the death. So we don't take the eye or cornea before the death of the patient. It's only after death, but we can pledge when we are alive. Next. Next slide.
One moment.
Yes. So eye donation, what is eye donation? It is donating the eyes of a person after death for transplantation with the family consent. So the more important thing is family consent. The transplantation is only known cure for corneal blindness. So this is important. Many people ask all kinds of blindness are curable. No, it is only the corneal blindness. Blindness which is occurring due to corneal impairment. Other structures of being normal, only those people can get the sight or vision after a corneal transplantation made by a donor of a healthy cornea. Next. So how does blindness occur? It may be due to some injury to the eye, resulting leading to corneal loss of transparency, corneal transplant, often being the main cause of corneal blindness. One donation can lead to two corneally blind people. A person can donate each cornea to two corneal blind people. Actually, if it is a lamellar keratoplasty, but in general, if it is a full thickness penetrating keratoplasty, we can give sight to two persons. And blindness causes a social and economic burden to the individual. And we know because of blindness, people cannot work, and their community, their part to the community is not possible. So there'll be a burden. There'll be a burden to the community, and blindness, corneal donation, and transplantation can kill blindness. Next. So what is corneal blindness? As I told, it's the common next only to cataract. So usually younger patients more usually it has more impact because they cannot go to work, they cannot go to college, or they cannot go to school, and their whole life will be useless without any eyesight. So it affects the people more injury. They are more prone for injury, and they go for corneal blindness. And blindness in the world is almost like 40 billion. It have increased towards about 15.6 million. This corneal and 60% of them are below 12 years. and additional every year this 40,000 being added every year. 40,000 coin being added every year. So the requirement of cornea per year is and blindness requirement is about 1.5 million, and donated corneas per year is only 35,000. So see, 1.5 lakhs and 35,000. So we need 1.5 lakhs of corneas, and donated corneas are only 35,000. So difference almost like more than a lakh. So surgeries which are fit for cornea among this 35,000 is only 25,000. So there is a huge gap between the demand and supply. That's why we are creating awareness corneal for a corneal eye donation, corneal donation, and transplantation every year. So eye donation has is hit by the pandemic, COVID pandemic, and by April 2019 to March 2020, it was about 50,953 corneas being harvested. And by April 2020 to March 2021, it has come down considerably to only 18,359. See, it's almost like not even half, 1/3 only has been harvested. This is mainly a drop is 52%, mainly because of the COVID pandemic. Eye banking was completely halt from March 24th to May 8th during the pandemic because of the COVID wave. And even after when the eye bank resumed, the collection was only from the non-COVID hospitals, and hospitals which are admitting COVID patients are still in the red area. They are considered in the red area, so we cannot harvest the cornea in the IMCUs in the red area affected by the pandemic. So it is very less. And the shortage has led to permanent blindness of 20 to 25% of patients, and hence high time to promote the awareness and the importance of eye donation and inculcate the urge to everyone to eliminate the corneal blindness by pledging their eyes. Next. So these are a few guidelines for eye donation. Who can donate? So eyes should be donated within 6 to 8 hours. This we know. Before it was 4 to 6 hours. Now we can donate the eyes from 6 to 8 hours, and anybody, irrespective of age, sex, and religion, can donate the eyes. And persons suffering from diabetes and hypertension can also donate eyes. Many think that patient with the diabetes and hypertension cannot donate eyes because their eyes will be affected, their retina is affected, they'll have retinopathies, and so their eyes are affected. If they donate the eyes, then the person who is getting the eye will also have a defective vision. People are thinking like that, but it is not so, because their retina is affected, not the cornea. So we are taking only the cornea. So we have to create awareness as who can donate and who cannot donate. So the total procedure takes only 15 to 20 minutes. Many think that it will take a long time, 1 or 2 hours. So it will have they will have difficulty in performing their rituals and all this disfigurement and all these things. If anybody is wearing spectacles because of refractive error, the patient who will also have their defective. Even if they have cataract or spectacles, they can pledge their eyes and they can donate the eyes. Next. Next slide. Next slide. So when the eyes must be removed, you know that eyes must be removed by 6 hours, and you should ask the person, like kith and kin of the dead, to inform the nearby eye bank immediately. So then along with the pledge form, we give the number of the nearby eye bank. So they have to inform the eye bank. and the eye bank personnel will come to their house and collect the cornea. Along with that, they take 10 ml. We will glucose at especially HbSAg. So all these things will collect 10 ml of blood. After the removal, the eyes will be analyzed and processed at the eye bank. Whether the cornea can be transplanted, what is the grading of the cornea, for whom we can give it, is optical quality or can be given for therapeutic arthroplasty. All those things will be done, and I analyzing the eyes at the eye bank. Next. So for ID to fill the application form, so every hospital college will have ask for application form. Now it is available online also. So you can go, or else you can go to the nearby hospital. Every hospital has a ophthalmology department. There you can go and give your eyes. You can go and give your name, address, whoever your relatives are. You fill it up. They will give a small card with a phone number. You have to call. So we will register you as the eye donor and provide the individual eye donor card. You call the nearest eye bank number 1919 being the general number, and within 6 hours we have to call. You switch off fan, keep the cooler cotton, and close the eyes. These are the basic things you have to do as you call the nearby eye bank. Next. So the eye bank personnel comes and they enucleate the eye. So enucleation is of two types. Like you can enucleate the whole eyeball, or you can take just the corneal button, sclerocorneal button. So first 10 ml of blood is collected. Then you put a drape and lid speculum. You do a 360-degree conjunctival peritomy. You cut all the muscles around, release the attachments. Then you cut the optic nerve and remove the eyeball. Then you keep a shell inside and close the lids. So you transfer the eyeball to a holder and transfer it to the eye bank. So it will take, it's a very simple step. Any ophthalmologist will be able to do within 10 minutes, 10 to 15 minutes is enough. So these are various instruments needed for lid speculum, scissors, conjunctival scissors, then enucleation spoon, then scissors, then shell and sutures. Next. So contraindication, there are certain contraindications, and like tissue from donors have hazard to the eye bank personnel and harvester. The person who is harvesting must be strictly avoided. Like the patient may have viral hepatitis, HIV, then acute viral encephalitis of unknown origin, Creutzfeldt-Jakob disease, suspected rabies. Next. Next slide.
One minute. I think it has started.
Okay.
I think you're good to go.
Yes. So death from unknown cause to be excluded. Death from neurodegenerative diseases like amyotrophic lateral sclerosis, Alzheimer's, multiple sclerosis, Huntington's chorea, dementia. These are contraindications for the corneal transplantation. We don't take the cornea and transplant it. So other diseases being myasthenia, Parkinson's, Creutzfeldt-Jacobs, active meningitis, septicemia, patients having congenital rubella, rice, active TB. Next. And active ocular inflammation, diseases with redness of the eyes and retinoblastoma, adenocarcinoma with metastasis, malignant tumors of eye, and neurotoxic snake bites. These are certain diseases we should avoid. And along with this, whom we should not take, there are various myths about eye donation, like whether we have to, we are eligible for donation. People will be thinking um, whether we can do it or not, whether we are eligible because the patient is very old, can we donate, or it will be useful, or it will be useless, it will be thrown in the bin. Like that, many myths about the eye donation are there. So this is the main reason why people are not going for eye donation, because we have a lot of old people dying in our country every day, but we get only 35,000 of cornea for transplant, for donation, and only 25%, 22,000 is being, 25,000 is being utilized. So we have a lot of people dying and their cornea is getting wasted. So we have to break these myths to increase the eye donation, and for that we have to uh, give awareness to the patients, to the general public, about the myths they have in their mind. So that is the main aim of doing this eye donation awareness fortnight every year. So one big myth is eyeball, if it is taken, the face will have disfigurement. So while the dead person is lying down for the rituals, it will be like empty sockets will be there. So that is not so. We'll place the shell and close the lids, and it will look as though it is a normal eye. So that is one thing which is a myth. And blindness in the next birth. Certain religions have this myth that if you take away the eyeball and if you bury the person without eyeball, then the next birth child will be born with empty sockets. So this is also a misconception, and this is going away nowadays, and we have to create awareness among the public. So aged people, this is the main reason why people don't give, because most of them die old, and old people will have a bad quality cornea, so their cornea will not be useful. That is what people think, but it's not so. So the lower limit is 1 year, and very old people can also donate their eyes, and depending on the corneal um, this thing quality, that can be used for various purpose. So age or mental condition, nothing is the criteria for donation. Anybody could donate. And the quality of eye donation, they think in India is very poor. So always they think anything coming from foreign will be good, and if you go for surgeries in the foreign countries, that will be of good quality. So in India, it will not be good, and our donors' cornea is not good. Our transplant methods are outdated. Not so. So it's all the same everywhere, and age, nationality, religion, race, caste, and color has no bearing on the quality of eye donation. So many also think corneal transplant are just an experiment. If it is successful, it's okay, but most of the times it's not successful. They are just doing experiment. Not so. It has been done for a lot of years together, and they are quite successful. And we have to tell the patients, and it will give the eye and sight, vision, life for many people. So one of the popular myths that they are experiments. That's not so. It is a true surgery which can give vision to many people. And consent from relatives. This is very, very important. Even if you have pledged the eyes, your family members should give their permission to conduct the procedure. We will get the signature from the nearest relatives, like a wife or the blood relative, or a son or a daughter. So the pledging is important. If you have pledged your cornea, you have to inform your nearby relatives so that after their death, they'll inform the eye bank. And the next thing is their consent from the kith and kin is also important. Next. So length of the procedure, they take it. They think it takes a lot of hours, 1 or 2 hours will be delayed. Not so. The entire period takes only 15 to 20 minutes. So whenever you inform, they'll come and only the travel time. Then they'll do it in 10 to 15 minutes. They'll remove and they'll push off, and you can do the rituals. Next. So there is whenever a patient, a blind patient comes, when we ask them whether they can go for a corneal transplant, they don't have that much idea. Mainly they think it's expensive. The transplantation of cornea is expensive. They have to give money for the cornea. So that is not so. Eyes and cornea are given free of cost. They are taken free of cost. We don't pay them, and they are given free of cost. Only the transplantation, the keratoplasty surgery, only cost will be borne by the patient. It's a misconception that cornea can be bought or sold. So they have people pledging has come down because doctors, they think when they are in the deathbed, doctors won't save their life because they want to get harvest all the organs from the dying person. No, not so. If you are completely dead, then only they will take the eyes. They will not make you die just to harvest your cornea. So that is one thing. So they take the pledging before death is a little less. Many people still think that this can happen. Not so. So if someone hasn't pledged their eyes also, they can, if the kith and kin wants their cornea to be transplanted, they can very well call the eye bank and they'll remove the cornea. So eye can be donated only within 6 to 8 hours after death. It takes about only quarter hour. The body is treated with respect and it will not be mutilated at all. Next. So only the cornea is being transplanted, and it is the only part useful in eye donation. Scleral transplants can also be done, but only cornea is mainly useful for vision. Only corneal blindness can be treated with eye donation. So if a patient is having a defective vision due to optic atrophy or some macular degeneration, all those things cannot be treated with a eye transplant. That we have to tell the patient. So eye donation works twice-fold because we have 2 eyes and 2 corneas can be given to 2 people to a minimum. So to a maximum 4 people, and it's only an act of charity. 2 people can benefit. The high successful rate of corneal transplant is high, and it is almost 90% operations can restore the sight to the person. So we are coming to the end of the introductory session, and at the end we will be playing a video on corneal transplant. You can see the video. We'll explain it.
Do we have video attached to the PPT, Dr. Kavitha?
No, it's separately sent to you, ma'am.
Thank you, Dr. Kavitha, for your immense and in-depth social aspect which has been shared with us. And I would like to really heartfelt thanks for coming with us and enlightening our students. Over to Amrita, please.
Yes, thank you so much, ma'am, for putting in all the
Thank
efforts
you.
to guide us, ma'am.
Thank you. Thank you, Kalai, for giving me the opportunity. Thank you.
Thank you so much.
With immense pleasure, I call upon our very own Dr. Kalaiselvi, ma'am, to give us an overview on eye donation. Over to you, ma'am.
Thank you so much for this. I have created my own opportunity to meet my students and others who have joined today. And I won't take much time in giving in-depth details of eye donation. As such, my all the speakers have taken enough parts to give the enough knowledge. So I will just take you an experience which I would like to share, and I would like to take you through, walk along how a person who has, because till now we are seeing the world, after some time, some disease or corneal injury or some whatever madam has already said, and the next speaker by 2 o'clock also, she will be explaining how does we get into that picture of corneal blindness. So in that prospect, and as madam has suggested all the social aspect as well, I would like you to come with me to take along a role play, which has been done by our optometry students. And after the end of the role play, we will just try to discuss across the experience which you guys have shared with this role play. Just hold on, I'll just share.
ஒரு கிராமத்துல ஒரு பெரிய ஜமீன்தார் வாழ்ந்து வந்தாரு. அவர் ரொம்ப தற்பெருமை பிடிச்சவர். அதாவது ஒரு விஷயத்த செஞ்சுட்டு அதை சொல்லி சொல்லி பெருமைப்பட்டுப்பாரு. அப்புறம் நிறைய தானம் செய்வாரு. அன்னதானம், ஸ்கூல் பசங்களுக்கு புக்கு, நோட்டு, பேனா எல்லாத்தையும் தானமா தருவாரு. ஒரு வாரம் சாப்பிடாம கூட இருந்துருவாரு. ஆனா தானம் பண்ணாம இருக்கவே மாட்டாரு. அந்த தானத்தை பண்ணிட்டு பெருமை அடிக்காமலும் இருக்க மாட்டாரு. அவர்கிட்ட நிறைய பேர் வேலை செஞ்சாங்க. அதுல ஒருத்தர் தான் முத்துலிங்கம். அவன் ஜமீன்தாரோட அபிமானி.
நாளைக்கு மாரியம்மன் கோயில் திருவிழா. ஊரே காலகட்ட போகலாம் பார்த்தா ஐயா திருவிழா ஏற்பாடெல்லாம் தடப்படலாம் நடக்குதுயா. எல்லா வருஷம் மாதிரியும் இந்த வருஷமும் என்னோட சார்பா அன்னதானம் 100 பேருக்கு வேஷ்டி சேலையும் கொடுக்க போறேன்டா. நல்லதுதானே ஐயா. இப்படி எல்லாம் தானம் தர்மம் செஞ்சாதான் நிறைய புண்ணியம் வரும். போன பிறகு ஸ்ட்ரைட்டா சொர்க்கம் தான். சொர்க்கத்துக்கு பாரு கண்ட நகை எனக்கு நகை. ஆமாண்டா, இது வரைக்கும் நீ ஏதாவது தானம் செஞ்சிருக்கியா? இல்லையா, சுத்திக்கவே இல்லை. நான் எங்க தானம் செய்யுது? டேய், தானம் தர்மம் செய்ய ஒரு கொடுப்பனை வேணுங்க. சும்மா தானம் எல்லாம் பண்ண முடியாது. சரிடா. டேய் வாசு, சொல்லுங்க ஐயா. பாருங்கடா, பிரமாதமா இருக்கணும். சரியா? டேய், கட்டோடெல்லாம் பெருசா இருக்கணும்டா. மறந்துடாதீங்கடா. ஐயா, வேட்டி சேலை கொடுக்கறதுக்கு ஏற்பாடு செஞ்சாச்சாடா? இல்ல, ஏற்பாடு முடிஞ்சிருச்சையா. நீ வந்தா கொடுத்துடலாம். சரி, வாடா போகலாம்.
ஜமீன்தார் மக்களுக்கு அன்னதானம் அளித்தார். மக்கள் அவரை வாழ்த்தினர்.
டேய் முத்து, பாருடா, இப்படி தானம் செஞ்சதால மக்கள் எப்படி வாழ்த்துறாங்க. இப்படிதான் புண்ணியம் சேரும். நேரம் சொர்க்கம் தான்டா, சொர்க்கம் தான். திறமை ஏதோ கூட்டம் நடக்குது. போய் பார்க்கலாம்.
வணக்கம், நான் அரசு மருத்துவமனையில் வேலை செய்கிற கண் டாக்டர். கண் மருத்துவ வாரத்தை முன்னிட்டு இங்க கண்தான முகாம் நடத்திட்டு இருக்கு.
வழக்கமாக இருக்கட்டும். யார்கிட்ட கூட்டம் போட்ட? என்ன கூட்டம் இது?
நாங்க எல்லார்கிட்டயும் பெர்மிஷன் வாங்கிட்டோம். உங்க ஜமீன்தார் கிட்டயும் கேட்டுட்டோம். ஒரு மனிதன் அவனுடைய 2 கண்களை தானம் செய்தால் 2 பேருக்கு, ஏன் 4 பேருக்கு கூட பார்வை கிடைக்க வாய்ப்பு இருக்கு. இது பல லட்சக்கணக்கான கண் நோய்களாலும் மற்ற பிரச்சனைகளாலும் கண் பார்வை இழந்துள்ளனர். அதில் பெரும்பாலும் நீண்ட நாள் வாழ வேண்டிய குழந்தைகளாகவும் இளைஞர்களாகவுமே உள்ளனர். உலகில் 5 பார்வை இல்லாதவர்களில் இந்தியர். 46 லட்சம் இந்தியர்கள் பார்வைகளை இழந்துள்ளனர். 35,000 பேர் கண் தானம் செய்கின்றனர்.
கண்ணை தானமா கொடுக்கணும். கண்ணை கொடுத்துட்டு நான் என்ன பண்றது?
சிரிக்காதீங்க. ஒரு மனுஷன் இறந்த பிறகுதான் கண்களை தானம் செய்ய முடியும். உயிரோடு இருக்கும்போது கண்தானம் செய்ய விரும்புறவங்க கண்தானம் செய்ய உறுதிமொழி கூட எடுத்துக்கலாம். டாக்டர், இறந்த பிறகுதான் கெட்டு போயிடுமே, அப்புறம் எப்படி? அறையில் ஃபேனை நிறுத்தி வைக்க வேண்டும். கண்ணில் பஞ்சை கண்களின் மேல் வைத்து மூடி வைக்க வேண்டும். பின்பு கண்ணாட வங்கியில் அறிவித்தால் அவர்கள் வந்து கண்களை எடுத்துக் கொள்வார்கள். இதனால் முகத்திற்கும் எந்த சிதைவும் ஏற்படாது.
கண்ணாடி போயிட்டீங்கன்னா எப்ப திரும்ப தருவீங்களோ? இங்க பாடம் காட்டணும், பால் ஊற்றணும், மழைக்காரங்களை வர வைக்கணும், சரகு வாங்கணும், இவ்வளவு வேலை இதெல்லாம் எப்ப செஞ்சு முடியுது?
கண்ணை எடுப்பதற்கு அதிகபட்சம் 10 நிமிஷம் தான் எடுக்கும். அது மட்டும் இல்லாம கண்ண வங்கியில இருக்கவங்க இறந்தவர்கள் வீட்டுக்கே வந்து கண்ணை எடுத்துட்டு போயிடுவாங்க. ஹாஸ்பிட்டலுக்கு எல்லாம் போகணும்னு அவசியம் இல்ல. டாக்டர், வயசானவங்க கண்தானம் செய்ய முடியுமா? எந்த வயதினரும் கண்தானம் செய்யலாம். கண்தானம் செய்ய ஜாதி, மதம், பணக்காரன், படித்தவன், படிக்காதவன் என்ற வேறுபாடு எதுவும் இல்லை. மேலும் கண் அணிபவர்களும் அறுவை சிகிச்சை செய்தவர்களும் சுகர், பிபி உள்ளவர்கள் கூட தானம் செய்யலாம். கண்களை என்ற பெயரில் கண்ணை விற்கவோ வாங்கவோ முடியாது. உயிருடன் இருக்கும் போது கண்ணை தானமாக கொடுக்க முடியாது. கண்தானம் செய்ய விரும்புறவங்க பக்கத்துல இருக்க கண் வங்கியில போயிட்டு பதிவு செய்யலாம். இது உங்க குடும்பத்துக்கும் நீங்க தெரிவிக்கலாம். ஆகவே கண்தானம் அளித்து பல குடும்பத்தாரின் வாழ்வில் வெளிச்சத்தை கொண்டு வருவோம். நன்றி.
ஏதாவது தானம் செய்யணும்னு ஐயா அடிக்கடி சொல்லுவாரு, அதனால கண்தானம் செய்யலாம்ப்பா. டேய் வாசு, இந்த முறை திருவிழா அன்னதானம் களை கட்டுச்சுடா. அருமை அருமை. ஆமாங்க ஐயா, கட் அவுட் எல்லாம் நல்லா சூப்பராங்க ஐயா. ஆமாடா, ஊர்ல செஞ்சுக்கிறீங்களே, கண்தானம் செஞ்சுக்கிறீங்களா? அதான் இத்தனை தானம் செய்யறேன்டா. அவசியமா இல்லை. அது வந்து ஒரு மனுஷன் இருக்கும்போது எந்த விஷயத்தையும் உலகத்துல விட்டுட்டு போனா
விபத்தில் முத்து இறக்கின்றார். அவர் தன் கண்களை தானமாக அளித்திருந்தார். அவரது கண்கள் தானமாக எடுத்துக் கொள்ளப்பட்டது. சிறிது நாட்கள் கழித்து
முத்தாண்ட இறந்த பிறகு அவரோட கண்ணை தானமா எடுத்துக்கிட்டாங்க ஐயா. அவன் கிட்ட அத்தனை முறை சொன்னா என்னோட பேச்சை கேட்கல. இப்ப மூச்சை கிடைக்காம இருக்கான்.
உங்களுக்கு ஒரு லெட்டர் வந்திருக்கு.
லெட்டர் எல்லாம் நான் எந்த காலத்துல படிச்சிருக்கேன்? நீயே படி.
ஐயா, ஏதோ பரிசளிப்பு விழாவா? உங்களை கூட்டிருக்காங்க. பாவம் ஜனங்க.
பாத்தியா, நான் செஞ்ச அன்னதானம் மற்ற தானங்களை பார்த்து எனக்கு பரிசு கொடுக்க கூப்பிடுறாங்கடா. இதுக்கு நான் அதிர்ஷ்டம் பண்ணிருக்கணும். நல்லா டிப் டாப்பா ட்ரெஸ் பண்ணிட்டு போங்க. கண்டிப்பா கண்டிப்பா. அப்புறம் பேச சொன்னாங்கன்னா இது வரைக்கும் தானம் பண்ணதை பற்றி சொல்லணும்டா. என்னதான் பேச போற? சரியா?
விழாவுக்கு வருகை தந்திருக்க அனைவருக்கும் வணக்கம். நம்ம நாட்டுல விஷயத்த செஞ்சுட்டு தான் இருக்காங்க. அதுல சில விஷயங்கள் தான் வெளியே தெரியுது, சிலது தெரியாமலே போகுது. நம்ம ஊர் சேர்ந்த ஒருவர் எவரும் செய்யாத தானத்தை செஞ்சிருக்காரு.
நான் செஞ்ச தானத்தை மதிச்சு இந்த விழாவுக்கு எனக்கு பரிசு கொடுக்க கூட்டதுக்கு நன்றி.
என்ற வார்த்தைக்கு செய்த தானத்தை நினைத்து பெருமைப்பட்டுக் கொண்டிருக்கீங்கன்னு நினைக்கிறேன். உயிருடன் இருக்கும் போது கண்தானம் செய்ய செய்துள்ளார். மனிதனாக பிறந்தா தானம் செய்யணும் என்று ஜமீன்தார் சொன்னார்னு கூறினார். அவரை தானம் செய்ய தோன்றின உங்களுக்கு நன்றி. அவர் கொடுத்த இருவருக்கு கண் பார்வையை கொடுத்துள்ளது. அவர் உலகில் இல்லாவிட்டாலும் அவருடைய கண்கள் இந்த உலகத்தை பார்த்து கொண்டுதான் இருக்கின்றது. மேலும் ஜமீன்தார் ஐயா, நீங்க சில வார்த்தைகள் பேசுமாறு உங்களை தாழ்மையுடன் கேட்டுக்கொள்கிறேன்.
என்னங்க பேசுறது? மகிழ்ச்சி. நன்றி நன்றி
ஐயா. ரொம்ப மகிழ்ச்சியா நினைக்கிறேன். நீங்க இந்த விழாவுக்கு வருகை தந்ததுக்கு ரொம்ப நன்றி ஐயா.
உங்களுக்கு டிப்டாப்பா ட்ரெஸ் போட்டு வந்தீங்க, ஒண்ணுமே பேசவே இல்லை. முத்துக்கிட்ட நீ இது வரைக்கும் தானம் பண்ணிருக்கேன்னு கேட்டேன்டா. என்கிட்ட தானம் பண்ற அளவுக்கு எதைங்கன்னு சொன்னான்டா. பணம் இருந்தாதான் தானம் பண்ண முடியல, மனசு இருந்தா போதும். சொல்லாம சொல்லிட்டான்டா. முத்து நம்ம எல்லாரையும் சொர்க்கத்துல இருந்து ஐயா. ஐயோ, எங்க போறீங்க? நான் முதல்ல போய் கல்யாணம் செய்ய உறுதிமொழி கொடுத்துட்டு வரேன்டா. ஐயா நானும் வரேன்யா.
That is the end of the role play. Actually, as I said, role play, most of you, everyone in fact would have been looking at towards a video of the role play which the students have done. I have seen them once. Really enjoyed the experience, really enjoyed their facial expression of the Jamindar, and everybody together, they put up a really a good show. I wanted everyone to experience the world without sight. So that is why I have just given up. This is what only the audio will be there for those people who will have already seen many things. But now that because certain kind of trauma to the or certain kind of illness to the cornea, they would have lost completely the vision, and hence only the audio will be visible, or audio will be heard by them. So nothing else matters, nothing else they can see. So I would like to urge everyone to, since you have experienced by yourself, because at this techie world, this last as this pandemic also have pushed us to that extent that we have most dependent during that period for teaching, learning, and to watch across everything, all this video mode and online classes, everything has been going on. Most of everyone would have experienced that. We have to that mode, and we will also be following a hybrid mode as well, both physical and as well as the online mode, right? Because the receiving the whatever the memory, both audio and as well as video, and for you students as well, the reception, I mean the reproduction capacity, it increases with both audio and video. So right now, as we had experienced this, so I would like to everyone to look at the pledging of our eyes, and hence somebody after we move on. It is not that during when it is required for us, we are not donating, we are not forced to give to somebody else. After our necessity, our need is over in the world, I would like everyone to look at it, how the world of those people will look at, and they will really feel so very difficult to get along with their own daily living, daily activities. And not only that, and if they are being the bread and butter winner of the family, the whole family is stranded and they might not be able to make it up, right? So kindly think at that, and we will just all I insist everyone to pledge our eyes as we live, and as we leave the world, we will donate our eyes to those in need. And with this, I won't I stop my speech and talk my overview of eye donation. Hope everyone has got the experience and you will all come forward. Thank you. Over to Amrita.
Thank you, ma'am, for enlightening us and taking the effort to give a really small and cute role play. So the program, so we are moving on to the lunch break actually. So
Yes.
the program will be starting again at 2 p.m. and I request everyone to kindly join back at that time. So
we have eminent two speakers who will be enlightening us for both corneal blindness, and next would be the surgical aspect of eye donation. So do join us by 2 p.m. We break us for the lunch break. Thank you.
மொத்தம் 3
பேசுறீங்களா? Audio also you can check.
1 minute, I have to. Am I audible?
Yes, please go ahead.
Ah,
Yeah, you are audible and visible as well.
audible. You're able to see the screen also, right?
Yes, yes. In the slideshow mode.
Okay. Yeah, fine. Yeah.
Yes, now it's fine.
Thank you. I'll just shift
Okay.
to the other tab.
Okay.
1 minute.
Yeah, sure. We can.
Okay. This is also visible, right?
Yes, this is WHO and PCB
Yeah.
definition of blindness. Question 9. Just check the moving also. Next slide if possible.
Yeah, 1 minute. Okay.
Yes,
I'm audible, right?
yes, you are audible very much.
Okay. Okay. Thank you. What time do we
Okay.
start?
By 2
Okay.
o'clock.
Okay. So till then, shall I stop sharing or
Yeah,
shall I
you-
be in the sharing mode itself?
I'll give the sharing mode. You can minimize and
Okay.
you can stop your video as well. Maybe by 2 o'clock we will resume back. Still we have
Okay.
15
Okay.
more
Okay. Then I'll
minutes.
switch on my video and audio 2 minutes prior to, 5 minutes
Yeah,
prior to.
yes, exactly. That
Yeah,
we will.
okay.
That will
Okay.
do.
Thank you.
Thank you, doctor.
I'm not share contents from my laptop. Can you again make me a co-host or something? Sorry, I'm sorry. Yeah. Is it seen?
Yes, Christy, we have seen your folder, your system screen.
Okay, the photo only is seen. 1 second. Yeah. Now is it?
Christy, your voice is breaking.
Ma'am, you were able to see my thing, PowerPoint. Oh, okay. Is my voice clear now?
It is less in intensity. I think.
1 second. I think I logged in from two IDs. I log off and then log in.
Now we are able to hear you.
Yeah, you're able to hear me, but I think
Yes.
this ID again you'll have to make me a co-host to share because I'm not seeing the share button enabled here.
1 minute. So this.
Yeah,
Can you check?
now it's fine. Now it's fine.
If you in your video mode too, we're not able to see you.
Yes, madam. 1 second. Is it fine now?
Yes, fine then.
Oh.
So we are able to see you, hear you, and also your presentations. So can we start? Can we shift the presenter to Priya madam and start the afternoon session? I think so.
Shall we start?
Yeah, Amrita, we will start the afternoon session. Yeah, please go ahead.
Welcome back, one and all. I hope everyone had a great meal and is ready for the next half of the session. So, with immense pleasure, I would like to invite Dr. T. Vijhaya Priya, the Associate Professor, Department of Ophthalmology from Indira Gandhi Medical College and Research Institute, Puducherry, to talk on the topic corneal blindness and eye banking. Ma'am, the stage is all yours. Please go ahead.
Good afternoon all. Am I audible?
Yes, ma'am, you are audible. And as
Okay,
well as
yeah.
your slides are visible too.
Visible. Yeah, thank you so much. At the outset, I would like to thank Dr. Kalai, HOD in charge, and the management of AVMC for having given me this wonderful opportunity. I hope all of you had a good lunch. Yes?
Yes, of course.
Yeah, so before we move on to the presentation, can we have a small activity?
Sure,
All of
sure,
you
ma'am.
must be,
Please go ahead.
Yeah, thank you. Now, all of you must be sitting with your mobile phones, right? So just go to the web browser. The ma'am has already told me that all of you are familiar with this Mentimeter app. So type in just menti.com. Join this presentation. Type in the code and then type in your answers. Okay. Definition of blindness as given by WHO and NPCB and VI, the National Program for Control of Blindness and Visually Impaired. Go to the web browser, type menti.com, use the code, submit the code, and then type in your answer and submit the answers. Just a small activity to get you all going. Kalai ma'am, is this slide visible? The Mentimeter app slide is visible?
Yes, yes, it is visible.
Yeah, okay, okay. Thank you.
The question is visible.
Your question is visible. Yeah, thank you. Go to menti.com in your web browser, use this code, and just type in the answer. The definition of blindness as given by WHO and NPCB. I'm waiting for your answers. Very nice. Yes, visual acuity less than 3/60. The best corrected visual acuity in the better eye less than 3/60. Any more answers? There's only one participant who's answered the question, who's attempted the question. Anybody else? Three by 60. Thank you so much, whoever that was. 3/60. The 3 bar option is not coming in MintiR. Three by 60. Yes. Go to the web browser, type in the code, give submit, then type your answer and submit again. Okay. Anyway, the right answer is, congratulate all of you whoever have answered. Right answer is the best corrected visual acuity in the better seeing eye less than 3/60 or a visual field less than 10 degrees. With this introduction, let me move on to the topic today, corneal blindness and eye banking. We finished that activity. Going by a few statistics, corneal blindness is among the major cause of vision loss and blindness in the world today, secondary to cataract and glaucoma. It is the second leading cause of blindness in most of the developing countries. And we are adding roughly 25,000 to 30,000 people who become corneally blind every year. And 90% of the global cases of ocular trauma and corneal ulceration are coming from the developing countries. This, I move on to my presentation. The objective of my session would be to make participants understand the various causes of corneal blindness, stress upon the importance of the hospital corneal retrieval program, and also eye banking and its functions. So I will not be going much into detail because most of it you would have read during your theory classes itself. I'll be giving you an outline regarding the etiology of corneal blindness. First and foremost, when we talk about etiology of corneal blindness, stands the infections. And in the infections, we have infectious keratitis topping the list. It can be viral, it can be bacterial, it can be fungal. Followed by trachoma, onchocerciasis, ophthalmia neonatorum, and leprosy. So let's look at each of them. So corneal ulceration, which is being discussed as a silent epidemic in the developing countries in the Southeast Asian region. Annually, we are adding roughly 1.5 to 2 million people who develop corneal ulcer, and that's quite a huge number. So in a study shown by Gonzalez et al., it is shown that the annual incidence of corneal ulcer in Madurai district of South India was around 113 people per 1 lakh population per year. In most of the cases of corneal ulceration, it is shown that the trauma is the precipitating factor which precedes to this corneal blindness. And even in children, ocular trauma tops the list, followed by corneal ulceration due to other ocular diseases, followed by vitamin A deficiency leading to keratomalacia and corneal ulceration, and prior penetrating keratoplasty getting infected. It is even more pathetic in preschool children. Atraumatic bilateral keratitis, the causes being severe protein energy malnutrition and also incomplete immunization. Though there are so much of advancements which have occurred in the medical field, we still have patients with corneal ulcer who end up going blind. The reasons being delayed presentation. There are many a times when we've had patients who have come to the OPD or who presented to the healthcare facility many days or even weeks after the onset of the symptoms. So this leads to a deep-seated infection and leads to also extensive corneal damage. Use of traditional eye medications. I'm sure it is very, very common in our part of the country. These traditional medications, like, it can be as simple as an onion juice, it can be an oil, it can be a breast milk, all these being contaminated. In addition to that, they also serve as culture media and also have toxic effects. The next thing is about the microbial diagnosis and sensitivity of the organism. It's not that every healthcare facility has the opportunity to find out the microbial diagnosis and find out the sensitivity organism and treat accordingly. So sometimes the treatment that is initiated may be ineffective. And most importantly, inadequate treatment can be because of the microorganism not responding to our medication, or most of the time it is because the patient not using the drops properly. However, the better side of this of corneal blindness due to corneal ulcers is that early intervention has got a potential to decrease the number of corneally blind people. Prompt diagnosis and initiating appropriate treatment for corneal ulceration will go a long way in decreasing the blindness due to corneal ulcers. The role of the government is to ensure that antifungals and antimicrobials are available even in the rural areas. Public health strategies and education to prevent corneal ulcers, like even if the patient has developed a corneal ulcer, they should be taught to approach an eye care facility instead of using traditional medications. And finally, visual rehabilitation of the scarred corneas by corneal transplantation is also another step which will go a long way in preventing corneal blindness due to corneal ulcers. Moving on to the second infections, namely trachoma. Roughly 1.3 million people are blind because of the disease, and amongst these, around 8.2 people have trichiasis. If you look at the picture on the right side of the screen, you look at the various clinical presentations that you can get here. The first picture is showing you the sago grain appearance of the corneal follicles that you see in the upper tarsal conjunctiva. The various spectrum. If you don't treat it, you're going to end up having scarring, especially in the upper lid like this. And the third picture is showing you trichiasis, or the misdirected eyelashes. Now, what happens because of trichiasis? These misdirected eyelashes go and keep rubbing on the cornea, resulting in ulcers which get infected and which in turn lead to corneal scarring and vascularization. So the easiest or the better option is to prevent it. Penetrating keratoplasty in trachoma patients are very difficult or very disappointing because of the extensive corneal vascularization, the ocular surface disorders that these patients have, and also presence of the entropion and the trichiasis that you get as a complication due to this disease. However, WHO has introduced the SAFE strategy. Now, what does SAFE stand for? S stands for surgery for trichiasis. A is for treating the clinically active infections with antibiotics. F is for promoting facial cleanliness. And E is improvement of environmental conditions, especially in the endemic areas. Moving on to the next infection, onchocerciasis. We have around 7 lakh people who have impaired vision because of onchocerciasis, and around 2.5 lakh people are also blind because of this. What are the various clinical manifestations? It can range anywhere from a live microfilaria that you're seeing here in the picture on the right side. In the anterior segment, in the anterior chamber of the eye, you're seeing a live microfilaria, or it can lead to a blinding keratitis. This blinding keratitis is because of the inflammatory response to the dead and degenerating microfilaria which are present within the corneal stroma. As a result of this keratitis, what happens? There occurs severe corneal scarring and vascularization. You also have posterior segment complications like chorioretinitis, and it also involves the optic nerve, resulting in acute optic neuritis, which if left untreated can lead on to optic atrophy. However, a lot of strategies which have been put in by the government in the form of vector control or the mass usage of ivermectin has led to the decrease in the incidence of onchocerciasis. Now, all of us are aware that any conjunctivitis with discharge in a neonate less than 28 days of life is defined as ophthalmia neonatorum. You have various organisms which have been postulated in the causage of ophthalmia neonatorum. We have infections like Neisseria, Streptococcus pneumoniae, staph, chlamydia, even herpes infections have been shown as the etiological agents. So the mother brings the child to the OPD with complaints of mucopurulent discharge and swelling of lids within 1 week after birth. So you have to be very careful in differentiating this condition from the congenital dacryocystitis cystitis also. So if left untreated, it can go in for some organisms which were shown in the previous slide have a tendency to penetrate the intact cornea, resulting in corneal ulcerations and secondary infections, resulting in scarring of the cornea. Sometimes these ulcers can perforate, resulting in adherent glaucoma. We can also end up having anterior staphylomas, anterior capsular cataracts. And because of these adherent glaucoma or an anterior staphyloma, what happens in a neonate? There is non-development of fixation because of this corneal opacity. And because of this non-development fixation, sometimes the child is brought by the mother with a history of nystagmus. So how can we go about preventing this? Prevention of sexually transmitted diseases in adults. Antenatal screening of pregnant women is very, very important. And when a child presents like this, early diagnosis and treatment of ocular infections, either by erythromycin eye ointment or giving 4th generation IV fluoroquinolones. The next infection, leprosy. It has both extraocular and intraocular features. Now, the extraocular features include facial nerve palsies, resulting in lag of ophthalmos, and madarosis. Intraocular features, all of you are aware that the patient can end up having a chronic granulomatous iridocyclitis, iris pearls, like you're seeing here at 6 o'clock position in the picture, that present dead bacteria. Pupils become myosed, like shown in the picture. There's also iris atrophic patches. There can be secondary glaucomas and cataract. What happens because of the facial nerve palsy? Like, see, what are you seeing in the picture? Yes, you're right. The left eye, the patient is unable to close the eye. And this inability to close the eye is termed as lag of ophthalmos. So as a result of lag of ophthalmos and loss of corneal sensation, what happens? The cornea gets exposed, resulting in exposure keratitis and ulceration, especially in the inferior 1/3 of the cornea. This results in repeated corneal ulcers, which in turn lead to corneal scarring and vascularization. However, public health education programs and the usage of multi-drug therapy for the treatment of leprosy has brought down all these ocular complications to a larger extent. Moving on to the next etiology, the nutritional disorders, you have vitamin A deficiency. I'm sure all of you must be aware of the WHO classification of ocular manifestations of vitamin A deficiency. You have the first stage, XN, or the night blindness, which might be the presenting complaint with which the child is brought to the OPD. Stage X1A is conjunctival xerosis. Stage X1B is what you're seeing in the picture. You have the bitot spot. Stage X2 is corneal xerosis. X3A and X3B are corneal ulceration, which we don't want the patient to develop. XS is corneal scarring and XF is xerophthalmic fundus. So again, this is also preventable. Emphasis is being laid on prevention and massive dose vitamin A dose supplementation, dietary implementation, and fortification of simple foodstuffs which are available for all of us, improving the immunization strategies, and also control of any precipitating infections which can lead on to vitamin A deficiency. The next cause of corneal blindness being inherited, they are called as corneal dystrophies. Now, what are these corneal dystrophies? These corneal dystrophies are nothing but a group of non-inflammatory disorders which can result in loss of clarity in one or more layers of the cornea. So there are various layers. All of you are aware, isn't it? The cornea has got different layers. So there can be loss of clarity in one of these layers, and there are multiple corneal dystrophies, amongst which I've just put up the important types. You have the macular dystrophy, the lattice dystrophy, which are the stromal type of corneal dystrophies. And then you have the congenital hereditary endothelial dystrophy and Fuchs dystrophy. Like the name suggests, the last two are endothelial dystrophies. So this is just a picture showing you the granular, lattice, and the macular dystrophies, which are nothing but stromal type of dystrophies. And you have two more, the congenital hereditary endothelial dystrophy and the Fuchs dystrophy, which are endothelial dystrophies. Most of the time, it is when you sit in the OPD, it is the patients who present with trauma. Majority of the cases, some days, are trauma cases. So this trauma can be as simple as a corneal abrasion, or it can be very or injuries which can lead to vision loss, like penetrating injuries or exposure to chemicals like acids and alkalis. When you look at the picture, next picture, you will understand why I'm telling that it is very debilitating, visually debilitating to the patient. So this is a case of penetrating corneal injury. Though this has been sutured well and the wound has healed very well, but there is a corneal scleral scar which is exactly in the visual axis, and definitely the patient will experience defective vision. The next two pictures you're seeing are that of as an end result of chemical injuries. So look at these. This will also contribute significantly to corneal blindness. The most common mode of injury is trauma with vegetative matter. We need to have eye programs and strategies targeting the high-risk ocular trauma groups so that we have a decrease in the corneal blindness because of trauma. Moving on to the next etiology, which is iatrogenic, namely pseudophakic bullous keratopathy. All of you must have studied about Vision 2020, isn't it? Vision 2020 mandates that cataract is one of the diseases which has been dealt with in Vision 2020. So as a result of Vision 2020, our cataract surgical rates have definitely gone up so that the blindness due to cataracts comes down. So as a result of this, sometimes during our cataract procedures, there can be damage to the corneal endothelium because of the instrument or because of the procedure per se. This can lead to the damage of corneal endothelium, resulting in corneal edema and decompensation of the cornea and postoperative bullous, pseudophakic bullous keratopathy. The next condition leading to corneal blindness are degenerative conditions. amongst which keratoconus is an important condition, degenerative condition, which leads to keratoconus. Now, what is keratoconus? It is a progressive disorder in which the cornea assumes a conical shape, which is secondary to stromal thinning and results in protrusion of the cornea. So if you look at this picture, this is not a normal cornea. There is abnormal protrusion of this cornea. There are various named signs which are associated with keratoconus. I'm sure all of you must be aware what these two signs are that has been put up. The first picture is showing you the Munson sign, which you get in keratoconus. And the second picture is showing you the oil droplet sign, which you can get in keratoconus. So these patients in the early stages can be treated with spectacles, followed by contact lenses. Nowadays, corneal collagen cross-linkage is being done. A few subset of these patients can be treated only with keratoplasty. The last condition resulting in corneal blindness are inflammatory disorders, importantly the Murren's ulcer and the Stephen-Johnson syndrome. So what is Murren's ulcer? It is, if you look at the picture, we'll understand that it is a peripheral ulceration which happens in the interpalpebral region. It usually spreads circumferentially and followed by central spread. And look at this picture, you have an overhanging edge like this. This is typically a Murren's ulcer. So what is happening here? You have thinning of the cornea, you have vascularization and scarring. At the end, you end up having something like the picture which is shown here. So you can treat that with topical steroids. Sometimes you will need a conjunctival resection, immunosuppressive therapy when steroids do not work. And finally, to visually rehabilitate the patient, we need to do with optical keratoplasty. To sum up, you have various avoidable and curable causes of corneal blindness, starting from infectious disorders to inflammatory conditions. So what are we going to do about this corneal blindness? So what is the solution to the corneal blindness that we have? The first and foremost solution is to do a good keratoplasty, about which the next speaker, Dr. Josephine Christy ma'am, will be talking about. And this number one solution can be attained only by collection of donor eyes. So for collection of good quality donor eyes, you need something called as eye banking, which should be of appropriate standards. Now, I will move on to my second half of my presentation on eye banking and its functions. What do you understand by the term eye bank? So eye bank is nothing but an organization which deals with the collection, storage, and distribution of the donor's eye for the purpose of corneal transplantation, research, and also supply of other tissues for other ophthalmic purposes. Like you can have a scleral patch graft. So you get the scleral patch from the eye bank only. So the first eye bank was established in USA in 1944. In India, the first eye bank was established at Chennai in the year 1945. And the first successful corneal transplantation was done in Indore in the year 1960. With this history, moving on to the eye banking system in India. It is a three-tier eye banking system. So at the base of the pyramid, when you look at the picture, you see that you have the eye donation centers. In the middle tier, you have the eye banks. And then in the topmost layer, you have the eye bank training centers. So what are the functions of each of these? So eye bank training centers are responsible for tissue harvesting, that is collection of the donor corneas, processing, distribution, creating public awareness regarding eye donation, and importantly, training and skill upgradation of the eye banking personnel or all the personnel who are involved in corneal transplantation and eye banking. So middle tier consists of the eye bank. The Vision 2020 has envisaged that each eye bank should cater to a population of 20 million each, and they should work in close relation with the eye donation centers which are affiliated to the eye banks. Now, what are the functions of the eye bank? Eye bank also deal with collection of donor eyes. They are also responsible for processing and storage and distribution and utilization of the highest quality of donor tissue for transplantation. Another important function of the eye bank is to promote public education and awareness regarding eye donation. Importantly, they are responsible for promotion of hospital corneal retrieval program, which improves the collection of donor eyes from hospital deaths. What is difference between the eye bank and the eye bank training center is that the training centers, in addition to all these functions, are also responsible for the training and skill upgradation of all the eye bank personnel. So this is just a pictorial representation. I just want to emphasize the fact again that eye bank involves collection, processing and storage, distribution and utilization of high quality donor tissues. They're also involved in research. Another important function is to promote awareness, like you see here, and also importantly to emphasize or to promote the hospital corneal retrieval program. The eye bank has an administrative component and has also got a medical component. So the medical director of the eye bank is a trained corneal surgeon. We also have eye bank trained personnel or technicians in that. We should also have a clerk from a storekeeper, a public relation officer, and a driver for the ambulance. Now, the administrative section will be responsible for the public awareness programs, the conduction of the eye donation activities, and they also tend to liaise with the government, the local voluntary, and the other healthcare agencies in fundraising and promotion of eye donation activities. Now, the medical section is responsible for collection of the donor tissue, the processing, the evaluation, the preservation, and distribution of the quality donor tissues. Now, the third layer or the third tier in that triangle in the pyramid is the eye donation center, who provide public and professional awareness regarding eye donation. I'm sure that is the reason why we are having all this presentation. We are celebrating the eye donation fortnight now. The eye donation centers coordinate with the donor families and hospitals to motivate eye donation and to harvest corneal tissue. They're also responsible for collection of serology and for safe transportation of the collected eyes to the parent eye bank or to the eye bank with which the eye donation center is affiliated with. What are the sources of eye donation in India? I'm sure the speakers in the morning must have told you regarding this. It is usually voluntary donation without prior pledge. When a person wants to or wishes to pledge his eyes, he or she should also let his family members know regarding his wish so that they will be able to donate the eye after the person's death. So voluntary donation after prior pledging also takes place. However, the function of the eye bank, or in a large way, we are promoting the hospital corneal retrieval programs. We have an hospital corneal retrieval program running successfully in our institute since 2016. So what is the role of this hospital corneal retrieval program? It was started in 1990. It focuses mainly on hospital-based deaths and encourages donation of eyes in those deaths. It's a combined method of motivation and grief counseling. If you look at the picture, you see there is a grief counselor who's counseling the relatives of the or the next of kin of the person who is dead. So this grief counselor counsels the patient and gets the eye donated after the death of the patient, and they act as vision catalyst and promote eye donation in hospital deaths. So what are the advantages and why are we talking about this hospital corneal retrieval program? The time interval, morning the speakers must have told you that the time interval between the death and procurement of the donor tissue is within 6 hours. So when a hospital death occurs, the eye bank counselor facilitates this eye donation, and this retrieval time is relatively less. It's relatively faster, so the viability of the donor tissue also becomes better. Availability of the medical records of the person. You're there in a hospital setup, you know what the cause of death, you know the other other systemic disorders that the person has been suffering from. Blood sample collection becomes much easier, and we tend to get more younger donor tissues, and availability of the death certificate is also feasible when you have a hospital death, and there is better spread of eye donation message. So the eye donation or the procurement of the donor tissue can be from either a pledged or even from a non-pledged donor if the next of kin gives consent in the case of a non-pledged donor. I'm just reinstating the fact that the eyeballs should be collected within 4 to 6 hours. And I thank Dr. Josephine Christy for sharing this video. It's a small video on how we procure the donor eyes. So all precautions should be taken to ensure asepsis. The first step is the conjunctival peritomy, which is being performed. Under full aseptic precautions, this procedure is performed. So a 360 degrees conjunctival peritomy is being performed here. And the attachments of the underlying Tenon's capsule is removed. The cornea has to be moistened frequently by applying lubricant eye drops. Next, the step is to detach the muscles, the extraocular muscles from the globe. After the extraocular muscles have been removed, you see the optic nerve guide going behind the globe. Then you have the enucleation scissors and the optic nerve is cut and the eyeball is taken out and placed in the Moyes chamber. And this is the Moyes chamber in which the eyeball is placed and safely transported. We also have to ensure that there is no disfigurement, and at the end of the procedure, the eyelids are closed, sutured, to ensure that there is no disfigurement which is present. Okay, now that we've collected the donor eyes, we have transported it to the eye bank. Now at the eye bank, what happens? The first step is a slit lamp examination or a gross examination of the donor tissue that has been collected. So under slit lamp, what are we looking at? We are looking at the clarity of the health of the epithelium, the clarity of the stroma. We are looking at whether the folds are there in the Descemet's membrane, and also we are looking at the endothelial cell count by using a specular microscopy. A specular microscopy will give you the endothelial cell count. We also have to ensure that the donor person is not having HIV, hepatitis B, and also HCV. So we also go about during serological analysis to screen these infections. Once all this is done, and depending upon the need, the tissue is either stored or distributed for surgical purposes. So the slit lamp grading involves the presence or absence of epithelial defects, the clarity of the corneal stroma, the presence or absence of an arcus senilis, the folds in the Descemet's membrane, and the endothelium. So depending upon all these 5 criteria, the donor corneal tissue can be graded as excellent, very good, good, fair, and poor. These poor corneas are not suitable for corneal transplantation. So once we do a gross examination of this donor tissue, the next step would be to go about storage of the donor tissue till it goes for transplantation. So what are the methods of storage? We have short-term storage up to 96 hours. We have the Moyes chamber where you store this in a 4 degrees Celsius in a refrigerator. The storage is feasible for up to 1 day. Then you have the Macquarie-Kaufman medium or the MK medium where you can store for up to 2 to 4 days. Intermediate storage is up to 2 weeks. You have the K-sol and the Optisol media. The U-sol, there are lots of media, but more commonly these are used. Long-term storage is using organ culture and cryopreservation. So So a little more into detail into what is being used commonly. We have the Moyes chamber technique. You have a seal chamber. If you look at the picture, you have the picture of the Moyes chamber. It is a seal chamber with saline and antimicrobial solution. This has to be placed at 4 degrees. The advantage is that it is simple and it is inexpensive. But the disadvantage is that the cornea, there is a possibility of cornea developing edema, and you can store it only for a limited duration. Within 24 hours, this donor tissue has to be transplanted. The next thing is the MK medium or the Meckere-Kaufman medium, which maintains the viability of the donor tissue for up to even 4 days. The other intermediate storage media include K-sol, Dexol, Optisol, etc. Now, all of these media have a few things in common. I'm not going to, I don't want you to remember all the things, but just ensure that you know what is present in it, so that you know when you talk about eye donation storage, you know the techniques of the storage of donor cornea. So all these all these storage things have tissue culture, which is needed to support life, the minimal essential medium, which has a composition which is similar to aqueous. It has Hebes buffer, which provides an optimal physiological pH, antibiotics, dextran, which prevents the tissue swelling, chondroitin sulfate, acts as an osmotic agent and prevents tissue swelling, and it also maintains endothelial integrity, and it is also enriched with various salts and amino acids, which enhance the cell and tissue viability during the storage of the donor tissue till it is being used for transplantation. Long-term storage methods, I'm not going much into detail. You have the organ culture, which maintains viability for up to 120 days, and cryopreservation. The cornea is stored in liquid nitrogen with dimethyl sulfoxide. Long-term storage is done at 80 degrees Celsius for a period of up to 3 months. So this is another small video as to what is done in the eye bank once the corneal tissue or the donor tissue reaches the eye bank. This is the Moyes chamber that you're seeing in the picture. Now it's a short video of what happens. This is the gross examination. The slit lamp examination is done. The tissue, the corneoscleral button, is first excised and undergoes a slit lamp examination and put in the MK medium and stored. Next, the serological investigations are performed to rule out HIV, HBV, and active hepatitis C infections. The next is the corneal endothelial cell count is done using a specular microscopy. This is specular microscopy showing the corneal endothelial cell count. A small video about what happens to the donor tissue once you grade it as excellent, very good, good, fair and poor, and then the corneal tissue goes for storage and your distribution according to the need. Eye bank, the way forward. What are we going to do or what is needed? We have to initiate exhaustive capacity building, training of all ophthalmologists in addition to the NGOs, the ophthalmologists in the regional institutes and the medical colleges have to be trained in the field of corneal transplantation. At the secondary level, we should maintain a registry of patients who are corneally blind. Appropriate referral to higher centers should be ensured. The district ophthalmic surgeons should also be trained in the management of post-operative patients with corneal transplants. There should be an effective network with the optometrist at the vision centers. It is the optometrists who work at the vision center level and with the health workers at the grassroots level in ensuring that patients with corneal trauma or corneal ulcers are referred immediately for further treatment. At the primary level, We have to ensure that the village level health volunteers, they mediate between the relatives and the nearest eye banks after death, and they facilitate eye donation. The ashas also can be used for creating awareness at the community level, and the optometrists are being trained in corneal retrieval so that home deaths are also maximally covered. We already have a hospital corneal retrieval program by which we ensure that the hospital deaths are being covered. So we can, the optometrists are also being trained to ensure that we have maximum collection from the home deaths also. So I just want to emphasize that most of the corneal blindness is preventable. Effective health promotion strategies is very important. Surgical intervention in treating corneal blindness is very difficult in a developing country like ours. So prevention and early treatment would be a more viable and a cost-effective method in the long-term reduction of burden of corneal blindness in our country. Before I finish, I want to understand your role in eye donation. What are the role of the MBBS students in eye donation? By deciding to donate eyes and to promote eye donation, you give someone the most precious gift of a chance to see. I want each and every one of you who's listening to this to be a vision catalyst and to promote eye donation or to spread the message of eye donation in your neighboring places. So I hope each and every one of you will act as a vision catalyst. Before we wind up, Dr. Kalai, you please give me time. One of you, can you just unmute yourself and answer this? The patient gives a history of contact lens usage. On examination, you see a ring infiltrate like this, and you see a growth like this in microbiology. So what is the diagnosis and what is this? Any volunteers? Dr. Kalai? I just have a few questions, that's all.
Yeah. Dear students, kindly answer madam's questions. Open yourself, unmute yourself.
Please unmute yourself. We have been talking for so long, isn't it? I just want some interaction, that's all. Right. The answer is, it is a feeding tract of acanthamoeba on a non-nutrient agar with E. coli only. Okay. Just two more questions. A 60-year-old female patient with who was a known case of primary open-angle glaucoma. The cornea shows tiny dark spots on the endothelium. The first picture on the left is the slit lamp microscopy. If you look at the slit lamp also, there are tiny dots like this. And this is a specular microscopy picture. What is your diagnosis? And what are those tiny dark spots? Anyone?
Yeah, unmute yourself. I have given the options of muting you, unmuting yourself.
Yes. Any volunteers? Okay, that's a case of Fuchs endothelial dystrophy. And what you saw, those dark spots are called as cornea guttata. The last picture. Following a severe scarring of due to a chemical injury, the patient underwent this procedure. And this is a slit lamp picture of that patient. What is this? Extensive scarring where corneal transplantation was not possible. What is this? Normally, when you have a scarred cornea, like you have a leukomatous opacity, we will plan for a corneal transplantation, keratoplasty. But keratoplasty, if it is not feasible, what do we do? The patient has undergone this procedure. That was a picture of keratoprosthesis. Okay, it was the front plate which was visible on slit lamp. I once again thank Dr. Kalai as well as the AVMC management for having given this opportunity on the eye donation fortnight. Madam, if you're not behind schedule, I will take questions.
No, you are up to the schedule. Thank you so much, doctor. You have given us in-depth knowledge So my students are a little more shy. Maybe they might have not opened up to you. Anyway, thank you so much for your presence here and your deliberation. Over to Amrita, please.
Thank you so much, ma'am, for sharing your valuable knowledge with us. So upon next, we have Dr. S. Josephine Christy, the consultant at Cornea and Refractive Service from Aravind Eye Hospital, Puducherry, to talk about eye donation surgical aspect. A warm welcome, ma'am, and the stage is all yours. Please go ahead.
Yeah. Okay, so am I audible and visible?
Yes, ma'am. You are audible as well as visible, and your slide is also visible.
Also visible. Okay. Thank you so much, Dr. Kalai ma'am, for giving me this opportunity and the AVMC management team. And there was an extensive talk by Dr. Vijhaya Priya madam. Thank you so much for covering most of the topics. So I'm going to keep my talks simple with some of the videos related to keratoplasty. So I'll be talking on eye donation and its surgical aspects. So a little bit on history of keratoplasty. So the concept of keratoplasty was there even before in the 80s, in 130 to 200 ADs. So, and in 1818, Franz Reisinger was the first person to coin the term keratoplasty. And Arthur von Hippel was the first who designed the trephine, and he did the first lamellar keratoplasty. And Fuchs described the pathology of graft failure, and this is important for undergraduates as well. So the first successful penetrating keratoplasty was done by Edward Kaiser, and Castrovija was famous for his instruments used in keratoplasty, and he designed the square-shaped grafts, which was done in the early period. And R. Townley Peyton owes to the initiation of the first eye bank. The concept of eye bank was started in 1940, and in 1944, the first eye bank was started in New York by Townley Peyton, and in 1945, immediately after that, we started in RIO Chennai by Dr. R.S. Muthaiya in Tamil Nadu. So types of eye removal. So this was clearly dealt in detail by Dr. Vijhaya Priya ma'am. So the enucleation can be done in toto. So where the whole globe is retrieved from the donor dead person's body. So, and in the recent days, we have transformed into in situ corneal scleral excisions. So they found that even from the while removing the eye, instead of removing the entire eyeball, removing just the cornea and the scleral part of it, actually have studies have proven to have shown that the endothelial cells have been maintained and the utilization rates have been increased because of in situ excisions. But one disadvantage is we might not be able to get enough amount of sclera, and we have to remember that among the whole globe, not only the cornea is used for transplantation, we also use some part of the sclera for patch grafts. So, and also during the recent COVID times, the Eye Bank Association of India have allowed us only to do in situ corneal scleral excisions in order to prevent too much of exposure to the disease. So eye banking procedure in detail, I think this procedure was already shown by Dr. Vijhaya Priya ma'am. So what are the factors that affect donor characteristics? So ideally, patient can donate at any age. So we are not supposed to say no for an eye donation, but for reasons where the eyeball can be very elastic and very tiny, we might not be able to use eyeballs which is less than 6 months of age, and more than 80 years of age, we presume that the endothelial counts are not very good, so they might not be used for optical purposes. Though we do enucleation for anyone who consents for an eye donation, and we might use them for therapeutic purposes or tectonic purposes. And depth to enucleation time, so normal recommended is as early as possible or until 4 to 6 hours. But apparently studies have also proven that even after 24 hours, eye donation can be done. And this should not be a contraindication for enucleation or retrieval from the dead person. And eyeballs, even taken within 24 hours, have been found to have a decent endothelial count and can be used for transplantation surgeries. And cause of death, somebody who is sick for a very long period of time and their eyeballs undergo a lot of other metabolic due to other metabolic activities. The endothelial cells are not very good for, if taken from a person who is sick for a long period of time, whereas sudden death like hanging or accidents, those donor corneas are supposed to be very good with good endothelial counts. And health of the donor endothelium is largely dependent on the age. So as you all know, the endothelial count is maximum when the patient is young. And as the patient ages after 40, it slowly comes down. And endothelial cells are one cells that cannot regenerate. So it is very important that a donor is graded by the amount of endothelial cells that they have. And for transplantation, we make sure that at least 1,500 cells per millimeter square is measured in specular microscopy. So after doing a specular microscopy, as you would have seen in the previous video shown by Dr. Vijhaya Priya ma'am, like so the globe, when it is examined, we examine whether it is like intact and it is not damaged. And after that, we also see for the cornea healthiness. So the corneal health is measured by the amount of endothelial cells, and this is done by using an instrument called a specular microscopy. So the specular microscopy is one important examination that we do after we receive the eyeball from a eye donation. So based on the functions, based on the endothelial quality and based on the clarity of the cornea, based on the intactness of the corneal structure, we decide whether to use it for optical purpose or for therapeutic purpose, or it should be used only for research and training, or can it be used for scleral patch grafts, and whether it is not suitable for surgery at all. So when do we decide it is not suitable for surgery? When any of their blood tests for HIV, syphilis, or HPS-AG, so any of these serology is positive, we will not be able to use for any surgical training or as well as for surgery. And if the blood sample from the deceased person is not available for testing, also we are not entitled to use it. Only when we have a negative serology, we are supposed to use it for training as well as for surgical purpose. So, and in other cases, when the globe is deformed, when the enucleation is not done properly, when there is when the cornea is torn, or when there's an opacity in the cornea, it becomes unsuitable for surgery. So preservation of donor button, I think this also was dealt in detail earlier. So moist chamber is the routine technique that we do. So whenever we enucleate as a whole row, we keep it in a moist chamber, and this can be stored in 4 degrees Celsius refrigeration for a maximum of 1 day or 2 days maximum. So by the end of 1 day, we try to take the cornea and the sclera, we process it in the lab under sterile conditions, and we try to transfer it into a intermediate storage medium from the moist chamber. We don't keep it more than 1 day in the moist chamber. So, so the next medium will be an MK medium. So MK medium, here it can be stored for a maximum of 3 or 4 days. So, and now we've all shifted on to an cortisol or an optisol medium, where the button, the corneal scleral, the processed corneal scleral button can be stored for up to a maximum of 14 days. So long-term preservation of corneal buttons, this has been of more interest in the recent days, because for the past 2 years during the COVID period, we did not have any enucleations. There was a drastic shortage of donor corneas. So we were all looking forward to what are all the alternatives for storing corneal buttons for a longer period of time. So one technique is cryopreservation, where it can be stored for a very long period of time, for even years together, in -196 degrees Celsius. The other preservation media that is available are glycerin preservation and gamma irradiation of grafts. So glycerin preservation is one that is very commonly done in the recent 2 years. Until then, we were not using glycerin preservation at all. But during the COVID time, we all shifted on to glycerin preservation, where the corneal button, once it is removed from once it is processed as a corneal scleral button, it is immersed in 95% glycerol, and it is completely dehydrated and vacuum sealed and stored in room, and it can be stored in room temperature for years together. And there's another technique which is available that's called as gamma irradiation, where the grafts are irradiated by gamma rays. And here again, it is stored in an albumin-based medium, and it can be stored in room temperature for almost 2 years. What are all the problems of these long-term preservation of donor button? Because whenever we preserve it for a longer period of time, be it cryopreservation or glycerin or gamma irradiation, all of these preservation techniques will damage the endothelial cells. So ultimately, you will have only a cornea which is completely devoid of endothelial cells. So these corneal buttons, which are stored for a very long period of time, cannot be used for any vision restoration, transplantation, or keratoplasties. It can be used only for maintaining the globe integrity or for tectonic purposes. So they'll not be able to get back their transparency, because for cornea to be transparent, their endothelial cells are very, very important. So when they are not there, so they'll just give us a tectonic purpose. So moving on to the type of keratoplasty. So as we already discussed, so after evaluation of a corneal button, we either use it for a full thickness penetrating keratoplasty or a partial thickness lamellar keratoplasty. So full thickness keratoplasty is where the entire corneal button is removed and it is replaced by a donor graft. And moving on to partial thickness keratoplasties, it can be various types. What is anterior lamellar keratoplasty, where only the anterior 300 to 350 microns of the cornea is removed and it is being replaced. And the deep anterior lamellar keratoplasty is called as DALK, where almost 490 microns of the cornea is removed and replaced. And there's something called posterior lamellar keratoplasty, where you replace only the posterior part. And this is otherwise called as endothelial keratoplasty. And there are two types in this. One is DSEC and the other one is DMEC. So DSEC is Decimet stripping endothelial keratoplasty, where the Decemets is stripped off from the diseased cornea and it is being replaced by the donor graft, which will have only the endothelium and little bit of posterior corneal stroma. In DMEC, where the donor graft will have only the endothelium and there will be no corneal stroma at all. So it will be a paper thin graft in a DMEC. So we will be seeing all these surgeries as videos in the next following slides. So types based on indication of keratoplasty. So the main indication is for optical purpose. That is the most commonest indication. We want to improve the vision. So as you all saw, the causes for corneal blindness. So when the cornea becomes scarred or becomes opaque, it becomes white in color. It will not be able to transmit the light, so the patient will not be able to see properly. So you have to change this opaque cornea with a clear, transparent cornea, so that will be able to give back the patient's vision. So for people with corneal blindness, their lens is fine, the vitreous is retina is fine, their optic nerve is fine, everything else is fine. Only the first part, the first refractive surface, that is a cornea, is not transparent. So we are going to change that part alone with a donor graft. And so the patient is going to get back their normal vision. So that is optical keratoplasty. What is tectonic keratoplasty? This is where there is a large tear on the cornea, where the cornea is melted off after an infection. So you just want to maintain the shape of the eye. You want something to close the eye with. So you for the integrity of maintain the integrity of the cornea, you want to do a transplantation, and not for vision purposes, then you do a tectonic. So that's why I was telling, for optical purpose, your endothelial counts are very, very important. Whereas for a tectonic purpose, where it's not for a vision purpose, but just to maintain the shape of the eye, then your endothelial counts are not, it does not matter, and you can transplant even a poor quality corneal button. Why this tectonic integrity is very important? Because if you don't maintain the tectonic integrity of a patient's eye, so in due course, the patient's eye will become thysical. Thysical means it becomes smaller in size and it becomes very obvious. It will be cosmetically unacceptable for the patient. So that is the reason why, when we know, in spite of knowing that this might not be able to give vision for the patient, we try to replace it with a corneal graft to maintain the shape of the eye so that it is cosmetically acceptable for the patient. And therapeutic purpose, coming on to the next indication. So where the infected cornea, so when the cornea becomes very ulcerated, and here we remove the entire infected cornea out and we transplant it with donor graft. And then even for cosmetic purposes, in some cases where the cornea is totally white and opaque, patients are not happy with it. We were doing cosmetic transplantation, but in the recent days we have options like corneal tattooing, where we ink the white part of the cornea, and also we've got colored contact lenses which will simulate a normal eye pattern. So now, what are the indications for optical penetrating keratoplasty? So optical keratoplasty is everything that gives back the vision. So a healed corneal ulcer. So an ulcer which has completely responded to the medical treatment, but it is healed with an opaque scar. And a keratoconus with a DM tear. So keratoconus was a condition, an ectatic condition of the cornea, which is already dealt with by Dr. Vijhaya Priya ma'am. So when it becomes scarred, then it results in a condition called acute hydrops. So in those cases, we go for a penetrating keratoplasty. A corneal dystrophy, a stromal corneal dystrophy, which is involving the endothelium also. It is involving the entire spectrum of the cornea, all layers of the cornea. Then you'll have to really remove the entire part of the cornea and replace it. And in case of failed grafts, this is some of the commonest indication, because most of the time people with corneal ulcer, we do a therapeutic keratoplasty for them. But then after some time, the graft fails, because as I was telling you earlier, for a therapeutic keratoplasty, we don't keep a very good corneal button. So we keep a button which is, we just want to remove that infected area and try to treat them as early as possible. So most often these donor buttons that we use for therapeutic keratoplasty will have very less endothelial cell counts. So by the time they heal and come back, they come back with an opaque graft like this. So now after their infection episode is all over, after the eye quietens, we'll have to plan for a new graft in order to give them back the vision. And bullous keratopathy with stromal scarring. So this pseudophakic bullous keratopathy, this can happen after a cataract surgery. Sometimes during the cataract surgery, the endothelial cells and the Descemet's membrane can become damaged. And if it has a stromal scarring also in a PBK, in a pseudophakic bullous keratopathy, then we might need to do a optical keratoplasty. And post-traumatic dense scars after a corneal tear, sutures are seen here. So if it is involving the central visual axis, then in order to give back the vision, we need to do a transplantation. So now this is the procedure for a penetrating keratoplasty. So there you can see an opaque cornea. So we are using trephines in order to trephine the deceased cornea. So this is the corneal button that we are going to graft onto the patient's eye. So now this clear corneal button is going to be replaced. So this is the deceased button which has been trephined. So once this is removed, so it's an open globe procedure. It has to be done with utmost safety precautions. So now the graft clear corneal button is sutured onto the into the host. So now we secure this with almost 16 sutures. The first 4 sutures are called the cardinal sutures. So because when we are going to put 16 sutures onto the patient's eye, we have to make sure that it is equidistant, radial, of adequate tension, and so that it causes very least amount of astigmatism as possible, so that it can give good vision post-operatively. So now after a post-penetrating keratoplasty, after all the suture removal is done, this is how a clear corneal graft will look like. You can see the peripheral opaque deceased cornea in the rim 360 degree, and in the central 7.5 to 8 mm, patient will be having a clear graft. So this is a standardized technique which is being used for a very long period of time. It is the most successful tissue or organ transplantation in the body, where it replaces the entire corneal pathology. So disadvantages are, I wouldn't say it as disadvantages, because for the patient it is going to give them the life back. But as a procedure, PKP has a long postoperative visual rehabilitation. Graft rejections can happen because the patient has to use the drops for a very long period of time. If the graft is not well taken care of, or if they discontinue to use their steroid drops, then the graft can reject. So once a graft rejection happens, it should be treated like an emergency. Otherwise, it can go for a permanent graft failure. There can be suture-related complications, suture-related infections, and the graft can give away, and there can be traumatic graft dehiscence. there can be risk of undue corneal toricity and high degree of ametropia. So even after a corneal graft, because of high amount of astigmatism, the patient might not be able to see clearly. And again, if the grafts are not maintained properly, they can go for a reinfection. So moving on to anterior lamellar keratoplasty, here only the partial thickness of the cornea is transplanted, where selectively we are replacing the deceased superficial layers alone. And we are going to maintain the healthy host endothelium. So the patient's endothelium is very good, very young. We are retaining the patient's own endothelium, and only the deceased anterior parts of the cornea is being replaced. So this is an animation which shows you what is being done. So you can see a corneal scar which is there anteriorly. So now this is a cross section which is showing. So where we are leaving removing the superficial parts and leaving behind the posterior decimus membrane. And then we are going to replace this scarred superficial part with a graft. So this is how a DALC is done. But in DALC again, you will have multiple sutures. So DALC again is not completely sutureless because you are replacing the anterior part of the cornea, and it again has to be sutured with either continuous or interrupted sutures amounting to around 16 to 18 or 20 sutures. The indications of DALC, most common indications are ectatic procedures. Like I said, keratoconus is a perfect indication for DALC. Only when it has not gone to the stage of severe acute hydrops or a DM tear or a stromal scar. So in the just before the advanced stages, keratoconus is a typical indication for DALC where it is ectatic. Okay, so we are removing the ectatic weak diseased cornea out and we are replacing it with a cornea, and we are trying to induce some corneal flattening so that the patient is able to see clearly. And the this is another procedure, another indication for DALC where keratoglobus. But again, keratoglobus PKP is also indicated. Another ectatic disorder is a pellucid marginal degeneration, where you can see an inferior corneal thinning. And this is a stromal raised buckless dystrophy, which involves only the anterior part of the cornea and not the posterior part of the stroma or the endothelium. Everything else is healthy and clear. So we are going to replace only the anterior parts. And this is another dystrophy, where in a lattice dystrophy, where the endothelium is not involved at all. So we will be removing only the deceased anterior part. Here again, in healed corneal scars, where only the superficial part alone is scarred and white, you can do a DALC. So in the DALC procedure, we remove the anterior deceased part, but in the host eye, there will be the decimus membrane of the host will be retained. Okay, and you take this is the graft button. From the graft button, we remove off the decimus membrane, because we are going to replace only the taken graft, only this part of the graft. So we are not going to use the entire graft button. So we are going to remove the decimus membrane from the graft button, and we are going to use only the graft button that is devoid of DM, and we are going to transplant in the host eye. So here you can see it is removed. After removal, this button is kept on the host cornea, and then it is sutured. So this is a method where a continuous and an interrupted suture is placed. So this will make sure that the astigmatism induced is as less as possible. So this is a video showing where from the graft cornea, so the decimus membrane is like a paper-like membrane. So we try to remove it with a wet sponge here. So once that is removed, then this graft will be suitable for transplantation. So this is a DALC surgery. So here after trephination, so we try to make sure that only the superficial part is being cut. So, and after that, how are we going to separate the superficial layer of the cornea from the deeper part? So we use a big bubble technique. It's called as an inverse big bubble technique. We go into a deeper layer and try to inject a large air bubble. So once this large air bubble comes, so this air bubble will separate the anterior parts from the posterior part. So once this separation is done, and then we slowly remove the parts of the anterior cornea by using a crescent plate. So once anterior parts of the cornea are removed, So then we decompress the air bubble and try to remove the other parts of the cornea. So now this DALT surgery requires lot of surgical expertise because getting a proper bubble and a good layer of separation is very difficult. It needs a lot of patience. So, and also we will be exposing the patients, the host Descemet's membrane, which is again paper-like, because we have to retain it back. We can't perforate it. Once you perforate the patient's Descemet's membrane, then he will not be eligible for an anterior lamellar keratoplasty. You will have to again replace the entire cornea because the Descemet's membrane is a very fragile structure. And the main advantage of a DALT procedure is we are trying to retain the patient's Descemet's membrane and the endothelial cells because these are all young patients. So their endothelial counts will be very high. So we are trying to retain their healthy endothelium and replace only the diseased part. So once this is done, then we keep this is the bare DM that is exposed. Then the graft is kept over the host DM and it is sutured. So these are the cardinal sutures. So 12 o'clock, 6 o'clock, 3 o'clock, and 9 o'clock position, the cardinal sutures are placed. And then here all interrupted sutures are placed. And then we keep an air tamponade so that the graft is well opposed. So now, as I told you, it's completely an extraocular procedure. So the intraocular complications are less because in a full thickness corneal transplantation, the entire globe is open. It's an open sky procedure. So at any point of time, you can have an expulsive hemorrhage. The entire contents of the eyeball can come out because of severe positive pressure. So there is a risk of losing the eye itself during a penetrating keratoplasty. So that's why I told you it has to be done under strict surgical precautions. So whereas a DALT, deep anterior lamellar keratoplasty, it is an extraocular procedure. So it has lesser intraocular complications and there is a rapid visual rehabilitation and patient will not have an endothelial graft injection because we're going to retain the patient's endothelium. And another good part is even the donor tissue of suboptimal visual quality. So as I was telling you earlier, so if the donor endothelial cells are very good, we use it for optical purposes. If the donor endothelial cells are less, we use it for therapeutic purpose or for tectonic purpose. But good thing is it can be used for DALT also because anyways, we are not going to use the endothelial cells in this surgery. So even of a tissue of suboptimal quality can be used for a DALT procedure. The disadvantages are it requires finer surgical skills and intraoperatively at any time you can have a DM perforation, a Descemet's membrane perforation, and therefore you should have a standby full thickness button also. And there can be postoperative complications like double anterior chamber, and in the interface there can be some haze and there can be suture related complications as well. So moving on to the endothelial keratoplasty, what do we do here? So here we are going to retain the patient's anterior parts of the cornea and only the deceased posterior part of the cornea is being replaced. So it is ulta of a DALT. So, so this is the recipient tissue. So this is the host eye. So here the anterior parts are going to be retained and this is the posterior part that is going to be removed. So the Descemet's membrane is going to be removed along with the endothelial cells. So it comes in one complex. So here in the graft, what are we going to do? So there can be two types of graft. It can be a DSEC graft or a DMEC graft. What is the difference between a DSEC and a DMEC? In a DSEC graft, so you will be taking the Descemet's membrane and the endothelium along with some amount of the posterior part of the cornea from the donor tissue. Whereas in a DMEC, you will be taking only a thin paper-like Descemet's membrane alone and you will be using it for corneal transplantation. So this is an animation. So now this is the patient's deceased eye. So you can see the deceased under part of the cornea alone is going to be released. So now we score the under part of the cornea alone with a reverse Sinski hook and we try to remove it. So it's, as I told you earlier, it will be a paper-like membrane. So that is removed and then the tissue is washed thoroughly. And then the graft, which is already taken from the donor, is inserted inside. And then we make sure that it is kept in position. And then we give an air tamponade so that it goes and sticks behind the back of the cornea. So this is the DSEC procedure in short. So where do we use a DSEC or a DMEC procedure? In case of posterior stromal dystrophies like Fuchs dystrophy, in congenital hereditary endothelial dystrophy, in pseudophakic bullous keratopathy where the cornea is edematous but the endothelium is damaged, and then aphakic bullous keratopathy. And even in post keratoplasty, sometimes there can be an endothelial graft rejection where the endothelial cells alone are not there, but the cornea becomes edematous because of their poor function. So there we can replace the posterior surface of the graft with another new graft. So this is another video which will show how we are be doing the graft for preparing the graft for a DSEC. So this corneoscleral button is mounted on in an artificial anterior chamber. So you create a chamber here. So by injecting air into one of the cannulas there, and then we do a lamellar dissection artificially. So once this lamellar dissection is done completely, now what we do is we put it on the, we place it, we take the corneoscleral button out and then we place it on a Teflon block like this, and then we refine it. We use a vacuum, non-vacuum refine punch, or you can use a vacuum refine so that you get a clear cut button. So once that button is done, we make sure that the graft is good. So this is how a transplantation is done. So here again, as we saw in the animation, we are removing the posterior surface of the corneal layer, that is the Descemet's membrane. So once you make sure that it is completely removed, we thoroughly wash the eye. And then here we do a needle technique insertion of it. So the corneal graft is taken. So the anterior part is not used. We use only the posterior part with some amount of stroma in it. And then by using a needle, we insert this graft into the head. So this graft, DSEC graft is little thicker because it has some amount of stroma also. Because it has some amount of stroma in it, it is easier to handle these grafts. So once we have made sure that it is centered properly, then we use, so this is the graft, you can see the margins of it. Then we use a air bubble to tamponade it so that it sticks onto the back of the cornea. So and post-operatively, so this is how the graft looks post-operatively. And this is a anterior segment optical coherence tomography, which will show you. So this is the cornea, this thick large one is the cornea, and if you can see the graft which is attached to the back part of the cornea. So it is well attached, there is no interface fluid or liquid, so it means that the surgery was successful. So in the DMEC, it is a very, very it has requires a very fine surgical skill. It's a very difficult procedure in order to peel only the Descemet's membrane and making sure not to damage the endothelial cells. So this is how the Descemet's membrane alone is peeled off. So stripping of the Descemet's membrane is very technically difficult because at any point of time the Descemet's membrane can get torn off. If the Descemet's membrane gets torn off while stripping, then it can't be used for surgery at all. So it has to be done with utmost precision. So and also we mark this paper-like graft. We mark it with some initials so that intraoperatively we know that we have kept on the right side up. Because if you don't keep on the right side up with the endothelial cells upside, so then your graft will fail completely. So for that sake, because it is very thin and paper-like, we usually stain the graft and we load it in a cartridge like this. So this is a DMEC surgery again. I'm not going to do the details. So this is how the graft will look like intraoperatively. So it will be like a blue paper-like sheet. So you have to maneuver so that it is in the right side up and it is centered, and ultimately we put air as a tamponade and opposite. So advantages of DSEC or DMEC is here we don't do any sutures at all because it is on the under part of the cornea. So the patient will have faster and better visual acuity recovery, and there will be least or no irregular astigmatism because we're not using any sutures, and there is less need for steroids and no suture-related problems, and less graft rejection and infection. So this is the highly successful transplantation procedure that we're doing until now. And but these can again during the initial stages can have complications. In between the interface, there can be fluid getting collected. The graft can reject, and it needs very fine surgical skills. That's about the surgical aspects of the eye donation. So if you were wondering what we'll be doing with the corneal buttons, so these are the various things that will be doing with our corneal buttons, and there are a lot of newer advances that are coming, which is equipping us to do to maximally utilize the corneal tissues. So any eye donation is not being wasted, and it is definitely being used for research and training, and we are trying to use it to the maximum. And thank you all once again. Thank you all for the support from AVMC as such. And I hope that this awareness activity and these fortnight celebrations would have on your attitude towards eye donation, and hope you will all serve as vision catalyst to promote eye donation. Thank you.
Yeah, we would definitely do that. And thank you, Christy, for your in-depth surgical videos. And I'm sure that our students would be definitely being benefited by your videos. Right? Thank you so much for coming and sharing your videos with us. And over to Amrita.
Yes, thank you so much, ma'am, for sparing your valuable time with us and sharing great knowledge. So next, we move on to the prize distribution, ma'am.
Yes. As per the celebration of our fortnight, we had given the awareness to those students, and we asked them to participate in various competitions, and out of which we had requested them for participating in various competitions like essay writing, digital posters, and one moment, let me just skip this. Yes, so out of this they all participated positively, and we have got a lot of essays for this evaluation. And I definitely should thank our ENT department and also our community medicine department for helping me in evaluating and scoring you guys, and of which I would post this first, second, and third. So the first prize goes to Ignatius Rajanda P. Good, congrats. And second goes to Muthu Krishnan R. And third, it should be third. Actually, third goes to Divya Darshini. So that is about the essay competition and its results. I think results would have been given earlier, and the prizes would come a bit later. So definitely we will send across you guys all those prizes for each 1, 2, and 3. And next would be the digital poster contest. So for which also we have nominated one. First prize goes to Suviksha AS, and her poster is also coming up next. And second prize goes to Sai Harish, and third goes to Samyukta SS. So this is Suviksha's poster. It's really good indeed, and it is the topmost scoring poster. And this is Harish one poster, and next is Samyukta's poster as well, right? So, and also we had entries for drawing competition as well. And on drawing competition, Megha Agarwal has bagged the first prize, and Ashwin Karthik second, and Nikhil has scored the third prize. Right. So this ends up with all those competitions and all those winners. Congrats once again for all the winners and all the participants for actively participating in the competition. And let us, as we have come to the end of this CME program. Yes, Amrita, can you?
Yes, thank you, ma'am. So we have come to the end of our beautiful session today, and I would like to invite Tamar Aragan AD, our very own class representative, to propose the vote of thanks. Tamar, please.
Please hold on.
Am I audible?
Yes, yes.
Good evening to all. I deem it a great honor and privilege to propose the vote of thanks on this memorable occasion. Let me first of all start by giving glory to Almighty God for making today's occasion a grand success. First and foremost, I would like to thank our Chancellor Dr. Ganeshan sir and Madam Chancellor Dr. Anuradha Ganeshan for their supporting in organizing this event. I would like to thank Dr. P.F. Kotu sir, Dean, who has been a pillar of support to this event. I would also like to thank Dr. V.N. Mahalakshmi ma'am, Dean HP, and Dr. Jaising sir, MS, and Dr. Vishnu Bhatt sir, Director of Medical and Research, for not only encouraging but also showing immense support for all these events. I would like to thank Dr. T. Rajan sir, VP Academics, and Dr. Arnachalam sir, VP Students Affairs, for their support. I extend my gratitude towards our chief guest, Dr. T. Kavitha ma'am, Dr. T. Vijhaya Priya ma'am, and Dr. T. Josephine Christy ma'am, who has taken time from their busy schedule to make this event grand success. It was informative, interesting, and really inspiration to all of us. I would like to thank Dr. Kalaiselvi ma'am, HOD in charge Department of Ophthalmology, for her contribution and support for making this event an unforgettable experience. I would also like to thank Optometry Department for their support. Now I place a record of gratitude to our panelists, Dr. Nishantini ma'am, Assistant Professor, Department of Community Medicine, and Dr. Soumya, a Senior Resident, Department of ENT, for their active support. My heartfelt thanks to my batchmates for their active participation in this event. I would also like to thank the 20th and 21st batch for participating in all the competition. Last but not least, I would like to thank the technical team for smooth conduction of this today's event. Thank you.
Yeah. With that note, we come to an end of the session, and participants can thank you for coming and participating in our CME. Thank you all, and I'll end the session. Thank you so much, everyone.